Welcome to a new live session with Medcare Hospitals. Today's session is about understanding endometriosis and treatment. And today we will have Dr. Charles Nagy, consultant OB and Gyno at Medcare Women and Children in Dubai. I encourage you to share your questions, and once I receive them from the live stream, I will share it with the doctor, and the doctor will answer them with us. Doctor, first, how can we simplify this, the endometriosis?
First, let me congratulate all women for the International Women's Day and Happy Women's Day.
Thank you.
We wish you all the happiness. And it coincides with the Endometriosis Awareness Month.
We have a very fruitful month this year. We had the kidney, and now this one, the endometriosis, and the women. So
Absolutely.
it's nice.
So endometriosis is a very common, chronic, debilitating disease that dates back to the 16th and 17th century, when doctors suddenly found ulcers in the abdomen and they couldn't explain it. Until the early 19th century or the late 18th century, when a histopathologist named von Rokitansky, who first named the disease as endometriosis. Endometriosis is the presence of tissues like the lining of the womb, but in the wrong place outside its normal existence inside the uterus. So it can be on the outside of the uterus, on the ovaries, the tubes, the bowel. It was even found in the liver, the diaphragm, the brain, and even the eye, the heart. So it can involve any organ, literally, in the body. These tissues behave similarly, but not exactly like the lining of the womb. So if you imagine during the ovarian cycle, the menstruation, the first half, the estrogen hormone will make the lining of the womb grow. And in the second half after ovulation, the progesterone hormone will make some changes in the lining of the womb to make it suitable for pregnancy. More or less the same changes happen in these, we call it ectopic endometrial tissue. So the normal period, the top half of the lining of the womb is shed out as the menstruation when pregnancy doesn't happen. Same process happens inside the abdomen or wherever these tissues exist, where the bleeding doesn't have anywhere to go. Okay. So it will continue to accumulate month after month and year after year, causing the organs to stick together. It can lead to damage of the ovary, the tubes, the uterus, or bowel obstruction, and it can invade even the bladder, causing bladder tumor and bleeding. Virtually any organ can be involved. So this is endometriosis.
Doctor, how could they, how early can we detect that there is a problem? So yes, we do get, period pain and back pain, but what are the symptoms that once we get it, we have to address it and go immediately to a doctor and do our tests?
First, we have to raise awareness that endometriosis exists, and it does cause severe pain in 80% of patients. Although some patients have endometriosis and they don't have symptoms. So there is no way to screen women for endometriosis. But we are guided by the patient's symptoms. Like from the age of starting the period, it is normal to have period pains, sorted out by minor tablets, analgesics, but it is not normal to have extensive injections, analgesia, and staying at home for a few days every month past the first year after the period. That should raise the alarm that there might be something else going on. And now with the recent advances of ultrasonography, we are able actually to diagnose endometriosis without the need for surgery, with great accuracy in many, many patients. So we strongly advise women who are having symptoms of pain, whether pain related to the period, pain related to intercourse, vague pain that they can't explain, bowel pains, bladder pains. Even some patients present with cough and coughing blood with very little symptoms of irregular bleeding between the periods. Any symptoms like this, that could be endometriosis. Some patients even complain of fatigue and weakness unexplained, although they are completely fit health-wise.
Hey, doctor, I'll pinpoint something that we had before our live session. You mentioned that we need to raise awareness among doctors as well.
Exactly. Because some patients can get the wrong channel into completely different specialty, and unfortunately, the doctor is not a gynecologist, is not aware that this problem is actually endometriosis. Like we had patients with severe upper abdominal pain that is not related to the period at all, not related to the gynae-bex. However, her symptoms are really worse during the period. So she goes to a gastroenterologist with a colonoscopy, a full check. The bowel is completely normal. But she has got a big endometriosis tumor on the liver. So it's very difficult actually to for a non-gynecologist to be able to keep that in the mind. The same also urologists. Patients could go with bleeding in the urine, and they get all the investigations, no stones, no infection, no nothing. But eventually it's endometriosis. So other doctors, non-gynecologists, they should know that endometriosis exists, and it can affect virtually any organ. Even cardiologists. We had patients with irregular heart rhythm due to spots of endometriosis in the heart muscle itself. So it can be that rare, but we need to raise awareness. Gynecologists, they should not take it lightly. Any severe pain in a woman in the childbearing age, that should be properly investigated. And we call actually for gynecologists to refer these cases to specialized centers for treatment and management of endometriosis, because we base our management in our center on a multidisciplinary care. So we have many specialists involved in the care of the same patient. We have colorectal surgeon, urologist, gastroenterologist, pain management specialist, dietitian, and infertility specialist. So we manage the patient according to her symptoms and according to her problem.
And doctor, is it genetic? Should it be, or could it be considered as a genetic disease?
It is partially. I mean, we don't know the exact cause of endometriosis, but the genetic inheritance of endometriosis is as complex as diabetes and asthma. So it is not a straightforward one gene that we can locate for endometriosis. And it is not enough actually to explain why endometriosis happens, because it happens in some women and not in other women.
Okay.
One of the theories that explains partly endometriosis is retrograde menstruation, where cells of the lining of the womb can come out of the fallopian tube and sit in the pelvis, and then it grows, which explains many cases of endometriosis, but it doesn't explain cases of endometriosis without a uterus completely. It doesn't explain endometriosis that happens in men. It has been recorded. So there is another theory to explain that there are certain cells in the body that are capable of dividing into any tissue of any organ. So these cells, under certain circumstances, they can divide into the lining of the womb, because the endometriosis is similar but not exactly the same. Also, there are theories to explain that it can go into the lymphatic system or the blood vessels from the pelvis to any organ in the body. Also, there is a factor in the immune system, because our immune system should reject any cells in the wrong place. But for some reason in these women, it doesn't happen. So genetic factors, retrograde menstruation, dysfunction of the immune system, metastasis, endometriosis behaves like cancer, but it is a benign disease. And the earlier we diagnose it, the better we can manage it. Although diabetes is not curable, but it's manageable. You learn how to manage it.
How to live with it.
The same for high blood pressure, the same for asthma. So we need to manage it, to diagnose it early, so we can manage it early and reduce the complications that can happen.
And the complications is what? Could it affect fertility and getting pregnant, or it could have a serious complications during pregnancy if it's not treated beforehand?
Well, complications are as wide as the organs that can be involved. It's a whole body disease. So severe pain during the period or after the period, that can impact on the woman's quality of life. And this is the most important point that we stress. Quality of life, the psychological impact. Patients from severe pain can get depression and anxiety, even in some patients suicidal thoughts, because they don't know what's going on. And the pain happens every month, and it's progressing month after the other. One of the major complications of endometriosis, of course, infertility. 50% of patients who have difficulty getting pregnant, they do have endometriosis at some point. This is why we advise patients, instead of going straight away to IVF, consult with an endometriosis specialist, because 50% of patients will have endometriosis. Endometriosis also can destroy the ovary completely, even in women who are not trying for a baby. But the ovaries are very important for the estrogen to stay healthy, for the bones, the heart, and so on. So the blood collection in the ovary, once it exceeds certain size, it can destroy completely the ovary, and the woman will have failed ovaries. In some cases, it can go silently, pressing on the ureter on one side or both sides, that it can lead to silent kidney failure. These are complications of the severe cases. Sometimes pneumothorax, which is rupture of the membrane surrounding the lung from bleeding inside. Sudden bleeding, sudden rupture of the cyst, if we don't know about it.
Okay, doctor, the treatment, you mentioned there's a treatment, or is it something that we live with? So you mentioned that if you have, kidney issues, or you have diabetes, you will live with it. With such disease, do we live with it?
We live with it, but in a healthy way.
Okay.
So like diabetics, they live healthy with the diabetes.
Yeah.
With endometriosis, once we know that there is endometriosis, we control according to the woman's age, fertility requirement, the extent of endometriosis, and the type of endometriosis and the organ involved. We advise for medical treatment as a standard to start with, even patients who need surgery. So medical treatment will not make endometriosis disappear. It will halt it for a certain period of time until we're ready for the surgery. But for some patients, when there is risk of kidney failure or severe back pressure on the kidney, we have to operate immediately.
But before we go to operation and surgeries, what kind of medical treatment you would put your patients on, and for how long?
Medical treatment, again, it's very baffling, because we don't know how it happens in the first place. So we have two groups. A group that causes pseudo-pregnancy state, because we know that during pregnancy it stops. It doesn't disappear, but it stops, because the hormone of progesterone, the hormones of pregnancy, will hold the endometriosis.
It goes on pause or hold.
Exactly.
Okay.
So these medicines called progestogens that will affect some changes in the endometriotic tissue and cause atrophy eventually. And this can be extended actually for many, many months. For as long as the woman is not trying for a baby and we know that she's got endometriosis and she has symptoms, she needs to stay in that.
Okay.
Other group of medications that stops the ovaries altogether, because endometriosis is estrogen dependent. And every time the estrogen goes up, the endometriosis tissue, they grow. So this is why estrogen is very important. So if we stop the source of estrogen, it can alleviate it. However, the mysterious thing, that even if we stop the ovaries completely, it doesn't stop. Because the layer of fat around the abdomen, it produces estrogen as well.
So there's another source.
Another source of estrogen.
To feed on. Okay.
And we also found that endometriosis tissue itself can release some estrogen. Do that. Hysterectomy or removing the ovaries is not on the agenda for treatment at all. We need to treat the endometriosis. Also, one of the new medications they want to try, we said about the immune system. So there is treatment to boost the immune system, to encourage the body cells to attack the endometriosis cells and get rid of it. We know that endometriosis develops its own blood supply and its own nerve supply. It's called angiogenesis. So some treatment as well called anti-neoangiogenesis to stop the new blood supply to this endometriosis growth. But to be honest, these treatments are still under trial, and we don't advise to use it generally for the patients, because we still don't have evidence that it works 100% without significant side effects. So the basic treatment is...
Doctor, during menopause, what happens? So does it appear or it doesn't appear completely? Is there any changes, or this is like a fine line age where it starts developing or not?
Endometriosis starts flourishing from the age of the first period up until menopause.
Okay.
But if it exists, it doesn't disappear after menopause.
So it doesn't, because I was under the impression that once, if it did not appear and you got to your menopause or you started your menopause, it will not come.
No, symptoms can get less, but endometriosis will never disappear, because we said estrogen can come from the fat layer. Estrogen can come from the active women who went through their life undiagnosed until they are about to have menopause. And they diagnosed with endometriosis. So the treatment is the main gold standard so far for the treatment of endometriosis is surgery, but not for every patient and not for every woman. There are other factors that we need to take it into consideration.
Okay, if we go with the simplification. So if we want to simplify the surgery, how is it done? Is it a big surgery that patients should take it seriously? How is it done? The recovery from it, and if it's done once, would it come back to the body, or it's once and for all? Once the surgery is done, it's not going to appear again in the body?
Very good question. Surgery for endometriosis takes a great deal of professional wisdom. So you need an endometriosis specialist who dealt with these cases before. We know it's a benign disease, but unfortunately it behaves like cancer. It sticks to tissue, and not only sticks to the tissue, it sends roots actually. And very interesting that it goes in the areas where the pelvic nerves. So it can surround these nerves, are very important for the bowel function, for the bladder function, and for the muscle function even. So in removing the endometriosis, we have to be very careful of the surrounding important structures. We have to be very careful of the ureters, carrying the urine from the kidney to the bladder, of the major blood vessels in the pelvis, of the pelvic nerves, and of course of the bladder and the bowel. So we surround the lesion using a certain high degree of magnification and laparoscopic equipment to remove the lesion. We know that sometimes we have to leave certain lesions for the sake of the woman's quality of life. It is not cancer, so we don't go and remove everything at the expense of the quality of life. Some women after surgery, they can have problems with the bowel or the bladder function.
Yeah.
It is a big surgery depending on the extent and the location of the endometriosis. In some cases, we have to remove part of the bowel that is about to be blocked, or to remove part of the urinary bladder if it's a big lump invading the urinary bladder. And it's the experience of the surgeon to decide which patient to have which surgery. And most of our patients are young patients, so they want to have kids after the surgery. So we have to weigh the pros and cons and be very clear and upfront with the patient that these are the complications that can happen. More than one doctor is involved. There is a colorectal surgeon, there is a urologist during the surgery to manage any complication. And nearly 100% of our patients, they have medical treatment first.
So they go on medical treatment before you go on surgery.
To control the symptoms, allow them some time to reflect on the next step, because it's a big surgery. They need to understand that they can end up with a stoma if it is complicated and we had to do it. Sometimes we remove part of the vagina. Sometimes we have to treat one side and not the other side, because the pelvic nerves go on both sides. So if we remove both, the woman could end up in catheterizing herself for life. And this is, of course, not a good outcome. So I can leave part of the endometriosis at the expense, without causing severe damage to the pelvic nerves.
Okay.
And this is why preoperative evaluation is very important for the patient.
So we don't reach to this point.
Yes. So we diagnose the endometriosis and we plan the management after discussion with our team. And we sit with the patient, this is the extent, and these are the possibilities before the surgery. So that she's aware that if anything happens, at least she accepts.
True. Doctor, is there any cases that you would recommend or you would have this conversation with your patients of pushing the surgery after pregnancy, after getting pregnant?
Exactly.
You can do that.
So this is what I'm saying.
They can wait until but definitely for some cases it's severe that they cannot wait.
Exactly. I never
so
tell
it's a case
the patient.
By case.
Yeah, I never tell the patient you choose between your quality of life or fertility. That is not right. And I should not ask the patient, do you want pain relief or the surgery? Of course, if the patient accidentally diagnosed of endometriosis, provided that the ovaries are fine and she's not in severe pain and she's trying for a baby, there is no harm in trying IVF first. She doesn't have to have surgery to have babies. We don't link this. But most of our patients who are having surgery due to pain, to the degree that it's affecting their quality of life and they can't go on anymore. Even after trying the medical treatment, some patients don't tolerate the long-term medical treatment, or they're not happy to continue on the medical treatment. So in these patients, the surgery is better.
And what kind of lifestyle would you put your patients on? Whether it's on a medical treatment or after surgery, what's the lifestyle that they should have?
Well, try to manage constipation, because most of these patients have constipation. Eating high fiber diet is very important. Staying away from certain food that cause fermentation in the bowel, like the dairy products and gluten-containing food. So staying away from these can reduce the bowel symptoms associated with endometriosis. The most important thing is being aware that endometriosis is benign. You have endometriosis, you learn how to live with it, be aware of the symptoms that can cause, be aware of the organs that can be involved, and seek the medical advice as soon as possible. And just adapt your life. It doesn't stop all women from having babies, and it doesn't impact too much on your work if it is treated and you manage it.
Okay, doctor, so we talked about infertility and we talked about pregnancy with the endometriosis. Okay, if we're talking about the youth age, once when the 16 and 17 age, because this is a question I got here. It looks like it's a mother who's concerned about this age from 16, 17. She's asking about the main signs or symptoms that if it appears, we should check.
Right.
She specified the age, so that's why.
Yeah. We had patients from the age of 14, 15. They presented with severe pain. And our radiology department are able to perform very accurate scans to check on the ovaries, to check on the uterus. If there is any major blood collection, they are able to do that. Even sometimes we do transrectal ultrasound to diagnose endometriosis. In some cases, the scan is completely free. And here is the awareness and the job of the doctor, to listen to your patients. We almost always, I believe my patients. If you have pain, I'm following this lead until I find out the reason for the pain. So believe your patient and continue the journey. They say actually laparoscopy is the gold standard for diagnosis of endometriosis. And although we agree in some cases where the ultrasound is completely free and there is no other organs involved, sometimes we have to do even chest X-ray to see if there is anything that explains the patient's symptoms. So if everything is free, we can do, and it is acceptable to be done, diagnostic laparoscopy to find out if these symptoms are due to endometriosis. Because the mysterious things, some patients, especially the young ones, they have mild endometriosis that causes severe symptoms. Other patients, they have severe endometriosis and they are not symptomatic.
True.
So we don't know how the pain mechanism works. So if at the age of 17 and she has severe pain, we do the ultrasound scan to rule out the obvious endometriosis, and then we can do a diagnostic laparoscopy. And this procedure can be done safely within 24 hours going home.
Dr. Charles, I really enjoyed the conversation and the topic. It's a very interesting topic, and I know, and we could spend hours and hours talking about it. But before we wrap up or we end the session, if you would like to share some tips, some raising awareness around this disease and what we should look after and what we should avoid, it would be perfect.
Yes, most probably actually be aware of your body and don't be shy to declare that you have pain with the periods or whatever pain you have. Go for regular check, please. For married women, go for regular check every 6 months and tell your doctor any funny symptoms you have. Even if you complain of just chronic fatigue and weakness, you'll be surprised that some patients, this is their complaint from endometriosis. Young women, please voice your concerns to your mom and ask for advice. Go for the check. It is not a taboo to go to a gynecologist to explore your symptoms. And you should not put up with the pain as it is not normal. So regular check, healthy lifestyle. Many endometriosis patients find having a regular hobby or exercise be very helpful actually to distract their mind from the pain. It is, although not curable, but it is a manageable disease in safe hands. The most important thing, read about it, know about it, explore your symptoms, and go for a regular checkup.
Dr. Charles Nagy, consultant OB and gyno at Medcare Women and Child Hospital at Medcare. Thank you so much for your time.
You're most welcome.
Thank you. Thank you so much for your questions, and see you in the next session. Take care.
Thank you.